Welcome to Patients at Risk, a discussion of the dangers that patients face when physicians are replaced with non-physician practitioners. I'm your host, Dr. Rebecca Bernard, and I'm joined by my co-host and the co-author of our book, Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare, Dr. Naran Alajba.
Good evening.
Most of us assume that if we have to be hospitalized, that our care will be overseen by a physician. But more than ever, patients are finding out that even if they have to be admitted to the hospital, that the care that they are receiving is not by a medical doctor, but often by a nurse practitioner or a physician assistant. Today, we'll hear the story of a patient who had such an experience. John Chamberlain's wife required hospitalization, and during her entire stay, her care was managed by a nurse practitioner hospitalist, and rather than a physician. John, welcome to the podcast.
Thank you very much. Nice to be here and appreciate seeing both of you.
John, you're the board chairman of Citizen Health, which is a healthcare cooperative working to redesign healthcare. And you also were a former hospital executive. So you know a thing or two about the healthcare system. So can you tell us about your wife's experience and what you saw?
She had my wife has Parkinson's, and we were in a hotel due to damage to our home from Hurricane Sally. Being in this part of the world, you're familiar with that. Iran, not so much. But she, one night, right as the night before Thanksgiving, she fell, lost her balance and fell and fractured the neck of her right femur, which necessitated a trip to the hospital ER and subsequent pinning of that particular injury. And we were admitted through the ER. And our first visit from the hospitalist was from a nurse practitioner, a very pleasant young lady. I was surprised to some degree in that 2 years prior, I went in for a hot gallbladder and I saw a physician hospitalist. And I happen to know the doctor or group of doctors that owns the hospitalist practice that the hospital contracts with. So again, I was surprised when we had a nurse practitioner hospitalist. At the time we were there, and it wasn't a complicated hospital admission, I wasn't particularly upset by it, but more concerned. She seemed to be knowledgeable to a point. And I think where I would have gotten upset if there had been any complications, I did not ask to see the physician because we didn't have those complications. But I think it's a dangerous step, and it's happening more and more in hospitals across the country. Had I requested a physician, I would have been very upset if one wasn't provided. Now, again, I know the doctor that owns the hospitalist practice, so I'm sure I could have requested through him to see a physician. I came to find out later that the doctor that was my hospitalist was no longer with them, but that's neither here nor there, except that it tells me that they're like everybody else, replacing physicians with lower cost, quote unquote, mid-level practitioners. And I don't find that to be a very pleasant trend. I think it's a dangerous trend.
I guess my question is, of course, you were once in that system, right? You were once involved with the hospital and an administrator. So from your perspective, I would love to hear, because it's one thing when we talk about it, when we own our own clinics, both Dr. Bernard and I, but I would love to hear about how or why you think really hospitals are replacing physicians. What are they getting out of this?
I think they're doing it primarily for a cost standpoint. Their hospitals, both not-for-profit and for-profit, have become more and more, lack of a better term, greedy. They have a lot of regulatory pressures. They're looking for ways to continue to put money to their bottom line. And that's why they're using lower cost practitioners, if you will. I think that's primarily it. I think they don't see anything wrong with that. And I have a big issue with that. I think, again, just so for general purposes, I think there is certainly a place for mid-levels as a part of a team. And I think had the mid-level that was over my wife's care from a hospitalist standpoint had said, well, I'm going to go back and speak to Dr. So-and-so about this. If you have any questions, that was never offered. but hospitals are doing it from a purely a financial standpoint. I think there's also pressure from regulatory bodies, not regulatory, legislative bodies. They're getting pressure from lobbyists, AANP, AAPA, you name it. Now we even got optometrists wanting to do eye surgery, which is just bizarre, beyond the pale. But I think it's a strictly financial. And again, I think there's some legislative pressure as well.
So I guess my second question then is something we've talked about a lot on this podcast is the studies really show that non-physician practitioners or nurse practitioners and PAs tend to order more studies, more labs, more imaging, and in fact, 400% more imaging studies than physicians do. And so can you talk to me a little more about how that's also benefiting hospitals? Because I think it is.
Obviously, from a financial standpoint, if you're working for the hospital, as a nurse practitioner or a PA, where are you going to refer those patients for imaging and diagnostic labs? Well, to the hospital, of course. And while you and I and Dr. Bernard may think, well, that's not good that they're doing, 400% more imaging ordering. Well, the hospital CEO thinks that's great because it's revenue in the door and they're revenue driven, whether you're for profit or as we're coming to find out more and more, the not-for-profits are even worse. Not only do they have a tax advantage, but they are able to get away with these things because of, quote, community benefit. And in reality, I just saw an article today that blew my mind. There's a hospital group, I think they're in Illinois, that has invested some of their largesse into basically an innovations or an acquisition unit as part of their hospital system, an investment fund. So they're looking to go out and buy companies to drive revenue for the hospital system. I mean,
Wow.
and I've worked at both. I've been both a not-for-profit CEO and a for-profit CEO. And the not-for-profits have been getting away with murder for decades. And it's high time that it comes to a screeching halt. But long answer to a short question, of course, they're happy with them because they're generating more revenue. And if you know what hospitals bill for imaging and labs compared to what a freestanding center would bill, it's understandable from that standpoint.
Absolutely. Now, John, when your wife was in the hospital, was in the state of Alabama. Is that correct? And
Yes.
if I'm not mistaken, I thought Alabama, is that an independent practice state?
It is not.
So it's not. So technically, nurse practitioners must be practicing under supervision or under a collaborative agreement with a physician. And yet, as far as you knew, there was never any physician involvement, or at least no one mentioned it to you at all.
That's correct. I think what would have been appropriate if it had been my employee as a hospital CEO and my nurse practitioner did not tell the patient, hi, I'm so-and-so, I work with such and such company, and it's Mr. Dr. So-and-so is our CEO, and I will be getting back to a physician overseer, for lack of a better term, and bring him up to speed, him or her up to speed on your wife's progress. Now, of course, because it was a surgical case, we had the surgeon came in and checked. Like I said, it wasn't a complicated medical admission. So, but then again, I think and if I felt like I wanted to reach out to this physician owner and tell him that, I probably would, and just say, look, just a bit of friendly advice. Some people are not going to understand why they're not seeing a doctor as part of their hospitalist routine.
And the other question that I have is, I know that when a nurse practitioner or a physician assistant is evaluating a patient and they're practicing under the license of a physician, they call that incident 2 when you do the billing. And if you're practicing under a physician and you're kind of filling the physician's plan, let's say, you're allowed to bill at 100% the exact same charge as the physician because you're acting as the physician's, quote, extender. Now,
Right.
NPs and PAs do not like this term physician extender these days, but that's the way the billing is set up. So that's called incident 2 billing. Now, if they are not working under supervision or they're not being directed by a physician, then they're supposed to bill under their own licensing number, at which they get paid 85%
Right.
of the billing. So
Right.
I also wonder, did you ever find out about any of the billing that happened? Were you being billed for physician level services, even though you only saw a nurse practitioner?
Well, interestingly enough, she was discharged on November 29th, and I've yet to receive an itemized statement from the hospital. So I don't know exactly how it was billed. Of course, I got my EOB from the insurance company. It wasn't detailed. I still haven't received an itemized statement. I was to the point where I wasn't going to pay until I received it, but you know how that goes. At any rate, no, I don't know exactly how that was billed out. I do know that there's an increasing prevalence of nurse practitioners outside the hospital as well. The last probably 4 visits my wife and I have had with our PCP have all been with a nurse practitioner. We haven't seen the PCP in probably 6 months, 8 months maybe.
Were you told when you scheduled the appointments that you weren't going to see your regular physician?
It kind of became automatic, you know, I'll see you back, nurse. And we've been, again, nothing serious, routine stuff. That would be a different story if it was my wife's neurologist and we were seeing a nurse practitioner, neurology nurse practitioner. That's a different story. But no, we were not told up front that you would be seeing so-and-so, you know, Dr. So-and-so's nurse practitioner. But again, we're happy with the one we've got so far as what our needs have been. But I wouldn't be afraid, and I happen to know the PCP, I wouldn't be afraid to stop her in the hall and say, hey, look, we'd really like to see you next time for this particular reason. And I'm sure, honestly, if I asked, I would probably be allowed to schedule with Dr. Birkenhauer.
But you shouldn't have to ask. And
No, I
how
shouldn't.
should you know? It's sort of like putting the onus on the patient to determine whether or not you need to be seen by a physician. And you're
Right.
very savvy and you know, you probably do know, but let's take the average person that maybe doesn't have that level of acumen, and they're supposed to know, like, well, this doesn't seem right, or I'm not getting better. I wonder if I should maybe see the doctor. I mean, that seems kind of, just not right, that the patient has to be the one to take that responsibility.
Yeah, it's very standoffish. And I think, again, my dad was an internist, diagnostic cardiologist, 5 generations of physicians. He would, of course, he passed a long time ago, but he was the kind of physician that would, if he wasn't seeing somebody, and of course he didn't have nurse practitioners when he was practicing, but if he had any questions, he'd just stick his head in. And again, if I were my PCP, if I saw you in the hallway or just knew you were in the clinic, and she's busy, I understand that. She's a fee-for-service practitioner. That's why she has 2 or 3 nurse practitioners working for her. But just to stick her head and say, hey, I want to say hi, see how you're doing, not to make her nurse practitioner feel uncomfortable, but I mean, that's part of business. You know how it is being direct primary care. And I'm sure Niran does in her business. It's more than just the clinical, it's the patient relationship. And I don't hold it against Dr. B. I know her, but there's going to be some point I'm just going to say, all right, look, how do you have us scheduled? We really think it's time, to see the doctor. And I'll be insistent about it.
Is she just as an example, is Dr. B in a freestanding independent clinic, or is she part of a hospital and employed as well?
She is staunchly independent. I've tried to talk her into going to DPC, get out of the insurance game for 5 or 6 years, and she's got it down to a system. She's happy doing what she's doing. She's obviously not in the clinic a whole lot with all the nurse practitioners working for her, but she would do fabulous in a DPC practice because she has that personality if and when you get to see her.
So, and again, not even talking about Dr. B per se, but what do you think? I mean, Dr. Bernard, of course, has a great DPC practice, and being pediatrics, I'm still a old fashioned classic, essentially a micro practice who still takes insurance, and I do fine. But I guess, what do you think the holdup is for physicians? Why do you think you're a business guy. What do you think is the holdup for people who really would be successful at DPC practices?
I think it's a fear of the unknown, for one. I think it's also huge medical school debt if you're trying to catch young doctors coming out of residency. I think it's, how am I going to pay? I actually had a young man that I was working with here 3 years ago, had an unsuccessful try at a for-profit hospital working for them as an employee over in Northwest Florida. And he called me up, we talked, and it came down to the fact, I said, look, you can open a DPC practice for next to nothing. Let's look for some real estate. I know where you want to be. You don't have to have near the space that you do as a fee-for-service practitioner because you're not taking insurance. You don't have the overhead, pure and simple. And his number one concern was he had massive medical school debt. He took a 2-year contract with another freestanding family practice doc near here. And I've been reaching out to him because I know it's coming up on the end of his contract to see if he's still interested. We did put our first DPC doctor in place about 45 minutes from here. I didn't participate in it directly, but I know the people that did, and I think he's doing very well. And it's my philosophy is if I am successful in placing one DPC doc in this market, I'll have 5 in less than a year because that model is that good.
Yeah.
And there are a lot of people in this market that don't have access to insurance. This is a tourist area, mom and pop, small employee groups that can't really afford to provide insurance.
Yeah, that's exactly my niche. Is I'm here in Southwest Florida. We have a very large group of patients that can't afford health insurance. They have, like you said, mom and pop businesses, a lot of roofers and tilers and cleaning people, good hardworking people just can't afford health insurance. And DPC
Right.
is a really affordable model. And like you said, it's super cheap to set up a practice. I opened a practice in less than a month. And,
Yep.
it doesn't take much. It doesn't take a lot of capital at all. I didn't even put anything into it. And 5 years in, I'm making more money than I made even when I worked for a for-profit hospital system where I was making very good money. So it can be done, and that we have to get past that fear and realize that DPC gives you back control and you can make a very good living doing it.
And you build it as you go. It's not like you have to walk in and have 2,500 patients in your panel as a fee-for-service doc or be an employee. That to me would be hell on earth, being an employee
Yeah,
of a hospital that's going to drive their revenue from my work, and I'm going to get a flat salary, and they're going to make all these facility fees and all this money from my referrals, and I'm still stuck at $200,000 a year as a family practice doc.
And, I think that's the biggest problem. We've spent a lot of time trying to educate patients as much as possible. You talked about a freestanding imaging versus a hospital imaging. And just as a reference, at least where I'm at in Washington State, it's 5 times the cost.
Oh, yeah.
So an abdominal CT costs 10 grand at a hospital, and it's
Yep.
1,800 at our freestanding radiology center. And what's amazing to me is patients will say, well, I got this x-ray, this chiropractor ordered this x-ray over at this hospital and it's so expensive. And I'm like, gosh, an x-ray costs $60. I don't know what you're talking about, $350. And they're like, well, that's the bill I got. And I always think to myself, that's the problem here. You have so many cooks in the kitchen, even as a regular insurance, I couldn't be employed either. That honestly would be like hell on earth. I completely agree with you. But what kills me is we're really cheap. Like we're really not that expensive. Yes, there's a copay, but beyond that, we do almost everything without having to do labs and referrals and all this other stuff. And I think I always say Nordstrom service at Walmart prices. That's kind of what my shtick is, whether, you like Nordstrom's or not. It's kind of a Northwest thing, but, in a nutshell, it makes a difference and people don't really realize how expensive these hospitals are. And that's the problem.
4 years ago, I got into a conversation with folks at Walmart corporate about opening a DPC clinic in one of their stores here. And we were this close. They said, you go out and find me 600 people, employers that sponsor 600 people, because I told them that was kind of a really good average DPC panel. And they said, you go out and find me that many employers that would be willing to commit, not necessarily sign on the bottom line, but present a letter of interest. And we'll look at just putting one of these clinics in one of our stores. And there's 3 in the area. Push came to shove and they went a different direction. They're now doing Walmart Health. And I just saw today where 9 of their senior executive in healthcare left the company. So that thing sounds like it's blowing up.
I just saw that too. I thought that was really interesting. They had this idea of offering comprehensive primary care, but not in a DPC model, more in a traditional model,
Right.
which we know just has too many middlemen. It has too many additional fees associated with it. The margins are so narrow when you operate like that. I think they realized that they were not going to make money even off of what they were going to sell to people shopping at Walmart after going to their doctor visit.
Right. I mean, the way to, and I believe in some of their demonstration clinics, they've got about 6 open. I think they had an office X-ray in the clinic, so at least they had some of that covered. They obviously have a good pharmacy program in the store, and yes, they're depending on that drive-by shopping while people are waiting for results or waiting to get in to see the provider. Now they said they were going to have physicians in all these locations. I don't know if that means literally on site or in a collaborative supervision role. I guess it depends on the state. But I think they saw what happened to Haven, and Haven crashed and burned because healthcare is difficult. It's very difficult.
Tell us
And so
about Haven for those that don't know about that.
Haven is the joint venture between Berkshire Hathaway, Amazon. I forget who else. They had a big, powerful name. Dr. Atul Gawande is their CEO, Jeff Bezos. And, it was really a lot to do. And Wall Street was ecstatic about it. And it didn't get off the ground, basically. They canned it within a year of announcing. Healthcare is difficult to do.
It's so interesting because they always talk about how we need to scale DPC, we need to scale it, make it bigger. But I don't think so. I think that's where it fails, as it becomes too big. There's too many managers. There's too many people getting between the physician and the patient, and it drives up costs and it decreases the quality of care.
Well, not only that, I learned a long time ago, healthcare is local. I don't care how big your hospital system is, if you're HCA or if you're whoever for profit, or your Banner Health out of Arizona or wherever, Sutter in Northern California. Healthcare is local. I don't care what kind of brand you try to put on it. It comes down to, and I had a very interesting discussion this afternoon, what we're doing at Citizen Health is trying to bring that back down to the physician-patient relationship. Everything else is third-party, middleman, intermediary. And that's insurance, that's PBMs, that's big pharma, big tech, you name it. All the digital health stuff that's flying around, it's all mumbly junk. And all it does is add cost and subtract value.
I've often said and of course, I'm only a 3rd generation primary care doc. I know you're, 5 generations back in your family.
I broke the mold.
You broke the mold. I'm hoping we get there eventually. But anyway, my grandfather was a family doc about 45 minutes from here in his own practice. Back when GPs did surgery, they did TNAs, they did,
deliveries.
Appendixes. Yep, you got it. He even did a C-section to deliver his 8th child on his wife. So again, those were those days where it was local. And, my dad obviously then was a pediatrician, and then here I am in the same practice. And what's crazy is every time they add a computer, they add a scribe, they add an extra person, insurer, whatever it is, it's another person in between me and my patient. Yep. And what's been fascinating to me is you're absolutely onto something when you say Citizen Health is looking at making healthcare or concentrating on the fact it's local. I have 3rd and 4th generation families. I have 1 4th generation. I have probably close to 100 3rd generation. They have for 3 generations been taken care of by a Dr. Olajba. Maybe not me, but the same name underneath it all, related to the original. And it's so different because, I had a new resident today. I'm telling the stories of these moms that I took care of as kids. I have tons of 2nd generation patients, and you're dead on. You're right on when you talk about local, because the whole point is that healthcare isn't about do this test and get this answer. It's knowing the entire life story of the patient and having it right here in your head, not in a computer, not over here. And that's what we're missing. And I guess my question for you is, you brought up the word provider, which has been, gosh, about every 6 months, it comes back on Twitter and everybody wants to jabber and babber about it. And in a nutshell, what is your take on the word provider as far as what it does with corporatization of healthcare?
I think it accelerates it. I think it demeans physicians that have more extensive training than is imaginable compared to a nurse practitioner or a PA. Not only that, I think the recent trend in NPs taking somebody off the street who has no nursing background, putting him in an accelerated program, They may have been an engineer and said, hey, you can make a lot of money as a nurse practitioner. I think I'll go do that. Well, I can tell you from experience, not everyone is cut out to be a nurse practitioner. And the ones that I know that have a nursing background, extensive nursing background, make the best nurse practitioners. And I'm not going to say they know their place, but they know where their heart is, where their experience is, and they know where they can be helpful, and they know where they just back off and take direction from the leader of the team. I think it's cheapened healthcare overall. You know, we talked a minute ago about scaling DPC. There have been a lot of attempts at that, and there's still some that are going on. The ones that come to mind that are abject failures were Q Liance out in your neck of the woods and Turntable Health in Las Vegas. Now, there are regional DPC companies, quote unquote, but guess what they're doing? Adding layers, adding cost. It just doesn't make sense to me. Now, is there a way to get all the independent DPC providers, pardon my expression, physicians, to collaborate on data sharing? Yes. And you don't have to be in the same network. You can do that. We can do anything. We can put a vehicle on Mars. I think we could maybe one day get rid of fax machines in healthcare. But I think back to your original question, I think the word provider, and you see all the memes with, you know, a pilot in an airplane and person getting off the stewardess saying, and I would like to introduce you to your provider today, who's flying the plane. Well, that's kind of the same scenario. It's sad is what it is. But again, a lot of that's coming from lobbying pressure. That's probably the number one thing I would remove is lobbyists. You think about lobbyists and their impact on healthcare. Well, they're having it on mid-levels, this internecine battle, if you will. But I think provider does nothing but cheapen it. It really cheapens it for everybody, because I think the good nurse practitioners are cheapened by it, and the physicians, of course, are cheapened by it. When you have somebody coming out of a 500-hour DNP program that was, I don't know, maybe they were flipping burgers. They're accepting anybody. A lot of programs accept anybody off the street, and you pays your money and you get your chances. You know, you too could be a nurse practitioner.
Yeah.
How much money do you have? You know, you don't have to pass the first 2 years. We'll give you another year if you pay for it.
Yeah,
that's not right.
That's the way it is. And it seems to me like corporations would like to lump us all into the same basket so that they can make equivalency between us. So they can say, oh, well, you're going to see the provider. And so patients don't ask, well, is that a physician? Is that a nurse practitioner? You know, we're all kind of lumped together in that same category. And so we don't, there's not as much transparency when you use that term.
And that's another word that I'm pretty much passionate about, is transparency, not only in that setting, but in pricing. I mean, you know, you talk about $1,800 for an abdominal CT. I can go to one of the green imaging locations anywhere in the country and get that CT with or without contrast for less than $1,800. You know, I mean, there are options out there, but people don't know. And the healthcare corporatocracy doesn't want them to know that there are alternatives.
John, when you think back to your days working in a hospital, did you ever see any of this coming down the pipeline, or what was this really a surprise, this rapid increase in non-physician practitioners? It
was really a surprise to me. My most recent experience with nurse practitioners was in an urgent care setting. I left a hospital CEO job, came to the Gulf Coast because my wife's mom was experiencing health issues. And I kind of started over. I didn't look for another hospital job because it's limited availability here, but I went to work and worked for a couple of different urgent care companies. And this was back in 2010, so 11 years ago. And we were just really starting to see nurse practitioners come into the urgent care setting. And everyone I worked with in both events was an RN who went back and got their nurse practitioner. And they were in a collaborative arrangement. The relationship with their collaborating physician was on site. It wasn't somebody from afar. So that dialogue, that exchange of information from NP to physician was immediate. You know, even if their collaborating physician wasn't there, the physician on duty was. And so there was no barrier between the NP and the physician, regardless of collaborating arrangement. And what that translated to was really good patient care. So instead of taking a guess as a nurse practitioner, of course, again, the ones I had experience with were knowledgeable and from experience as well as training. There's no guessing. If you don't know, don't do it. Get an answer, because the person that's in the middle of that is the patient. And that's who we lose sight of all the time. The corporatocracy doesn't care about patients. The PBM doesn't care about patients. The GPO could care less about patients. Physicians still care about patients. And that's another reason I couldn't work as a physician employee, because you're pretty much told, don't worry about it.
Right.
Well, yeah, this is my patient and my name's on the chart, and I am going to worry about it. But then again, you can only butt your head against a wall so many times until you quit doing it.
Exactly. So you mentioned that fortunately your wife had a relatively straightforward hospital stay, so no complications. So you were okay with having the management with a nurse practitioner because you did have physician involvement, the orthopedic surgeon. But what would you advise to patients if they were in a hospital situation or any clinical situation in which they weren't sure about whether they were getting the right care, or there were complications and they were being cared for by a non-physician? What advice would you give them?
I would tell them, if you're seeing, your only exposure to a hospitalist and you're required by, virtue of your admission to this facility, and you're only seeing a nurse practitioner and you have questions about what you're hearing, especially if you have questions about what you're hearing, ask to see a physician. I would say that in general. Ask to see a physician at some point during your stay, especially again with a complicated medical admission. I mean, my wife's mom was in the hospital several times since we moved down here several years ago. She passed a few years back, but there was one of us in the hospital 24/7. One of the family. We were there 24/7. And there were at that time physician hospitalists in addition to her specialists. So, but that's changing. That's changing so rapidly. I would advise anybody going into the hospital today, if you don't have a physician hospitalist that you've seen within the first 24 hours of admission, ask for one.
And then in the same token, what would Citizen Health and really you like to see out of transparency? I mean, what would be the ideal kind of future transparency in a clinic?
I think what we're looking to do is restore the physician-patient relationship. And if that involves, let's say, for instance, it's a fee-for-service practice and it's an independent practice and there's a nurse practitioner employee, we would like to see the relationship extended to certainly the nurse practitioner. There'd be basically three people involved: the patient, the physician, and the nurse practitioner where appropriate. But from a transparency standpoint, I think it's really incumbent upon the physician, who is the leader, to be transparent. And if for some reason they're not going to be there at the appointed time, they're going to need to let you know, need to let the patient know, I'm going to have Becky see you today. I'm not going to be there, but I'll be available to you after your visit if you have any questions. So transparency is important. Now that's a big word, covering a lot of ground. And we're seeing a lot of issues now around pricing transparency for services. And hospitals are by and large saying, we're not telling you. We don't care if it is a federal law. It's going to cost us $109,500 to be non-compliant. And so poof, we'll write you a check today. Well, that's not the point. And the point is, there are going to be people, there are going to be hospitals in markets that are going to say, hey, we're going to take this bull by the horns and we are going to be transparent. And we're going to show you, we're going to shame you into being transparent, because we're going to show you how low our prices are or can be. I had that work 25 years ago in Louisiana. We had one hospital in the entire state that didn't want to participate in a statewide data gathering. So I just called the CEO and I said, you know what? You're the only one, and we're just going to back into your numbers. How's that? Immediately, that same day, they decided to join in. So it's doable, but I mean, they've gone so far as to put coding into their software that blocks that transparency information. Some hospitals have done that, and they're getting found out, and Congress is not happy about it. There was a letter written by a group of congressmen to Secretary Becerra, the new HHS secretary, said, you know, you need to fix this. This is not right. But what'll happen then is the ones that don't want to do it will just pay the fine.
Well,
And
we're
I
so
talked with David Ballot about, because he was involved in the legislation. I said, we've got to get some teeth in that penalty. And he goes, we can't do it.
Hmm.
Can't do it right now.
Well, we're so glad for people like you that are holding these corporations' feet to the fire and also speaking out so that patients know what's going on. And so I'd like to thank John Chamberlain, the chairman of the board of Citizen Health. Citizen Health is the name of it, correct? Yeah.
Correct.
And you can find him at his website, citizenhealth.io. So thank you so much for being with us. And of course, to learn more about this topic, we encourage you to get our book. It's called Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare. It's available at Amazon and at barnesandnoble.com. And of course, we'd encourage you to subscribe to our podcast and our YouTube channel. It's called Patients at Risk. And if you're a physician and you'd like to learn more about how to promote physician-led care and truth and transparency, we encourage you to join us, physiciansforpatientprotection.org. Thank you so much, and we'll see you on the next podcast.